Welcome to the deep dive. Today, we're looking at neurosurgery from a different angle, literally the prone position.
That's right, where the patient is positioned face down for some really critical procedures.
We're basing this on a document detailing the prone position in neurosurgery, and our goal really is to get under the skin of why it's used, the benefits, the drawbacks, and, all the crucial details involved.
Absolutely.
So let's jump right in. Why would a surgeon opt for this, face-down approach?
Fundamentally, it's about access. The prone position gives us the clearest, most direct path to structures at the back of the head and the spine.
Okay.
We are talking specifically about lesions or abnormalities in the cerebellum, which is at the back and the base of the brain, and the brain stem connecting the brain to the spinal cord. And it's also very common for spinal surgeries, allowing access to the posterior elements of the spine.
Okay. Cerebellum and brainstem lesions. Can you maybe break that down a bit for, those of us not in the field? Why is getting to them from the back the way to go?
Sure. Think of the cerebellum tucked away at the back underneath the main cerebral hemispheres. And the brainstem is just below that, the core connection running down to the spine, handling things like breathing and heart rate. Often a tumor there is simply closest to the surface at the back.
So it's the most direct route, less navigating through other brain tissue.
Exactly. It gives us a clear and unobstructed view of those posterior structures.
Makes sense. Direct access. Are there other advantages to being prone?
Yes, another significant one, especially compared to the older sitting position, sometimes used for these surgeries, is a reduced risk of a specific complication called venous air embolism.
Air embolism? That sounds, not good. How does being prone help prevent that?
Well, imagine tiny air bubbles accidentally getting into an open vein during surgery. If you are sitting up, gravity and pressure gradients can unfortunately help pull that air toward the heart. When prone, the pressure in the venous system are different. It's generally higher, which makes it much harder for air to get sucked into the vein in the first place. It's a bit safer from that specific perspective.
Okay, right. Like trying to blow bubbles underwater versus in the air.
That's actually a decent analogy, yes.
Okay, so direct access, lower air embolism risk, but it can't be all positive. What are the disadvantages, the challenges?
It's definitely challenging. A major one is potentially increased venous bleeding because, as I mentioned, the venous pressure is higher. When you are prone, small veins might bleed more readily. Also, the ventilation can sometimes be trickier. The pressure on the patient's chest and abdomen needs careful management so it doesn't impede breathing or lung function.
Right. The weight of the body pressing down.
Precisely. And then there are the pressure related complications. We have to be incredibly meticulous with padding. Pressure sores on the skin, and more seriously, nerve injuries can happen if bony areas or vulnerable nerves are compressed for a long time during the prone position.
Increased bleeding. Does that require special techniques during the surgery itself?
It requires constant vigilance, meticulous hemostasis, stopping bleeding, and careful positioning to start with. Using specialized frames or supports helps reduce that intra-abdominal pressure we talked about, which in turn lowers venous pressure.
Okay, that leads nicely into the key considerations. Positioning comes up first, things like a Mayfield clamp and that abdominal support. Tell us about those.
The Mayfield clamp is a head holder, uses 3 or 4 small pins that attach just to the outer layer of the skull to keep the head absolutely immobile. Essential for neurosurgical precision.
Wow. Okay. Very secure.
And the abdominal support, often rolls or a special frame like the Wilson frame, lifts the chest and the pelvis off the main table surface. This allows the abdomen to hang relatively free, minimizing that pressure on the big veins inside the abdomen, like the inferior vena cava, of course.
That's about preventing those sores and nerve issues.
Exactly. Every potential pressure point, the elbow, the knee, the face, the chest, needs careful cushioning with the foam or gel pads. We check and double check to make sure nothing is being squashed or stretched inappropriately.
Okay, then there's head position. It mentions careful flexion and facial support. Sounds delicate.
It is. A certain amount of head flexion, bending the chin toward the chest, can sometimes help open up spaces between the vertebrae in spinal surgery, for instance. But too much flexion can be dangerous. It can kink the endotracheal tube needed for breathing, of course, obstruct venous drainage from the head, or even potentially compromises the blood flow to the spinal cord itself.
A real balancing act.
Absolutely, and facial support is crucial to avoid direct pressure on the eyes, for example, the most important, which can cause serious vision problems, and to ensure the airway tube isn't dislodged.
Anesthesia is listed next. Monitoring cardiac output, venous pressure. How does being prone impact the heart and circulation?
Well, the positioning can shift blood volume and affect how efficiently the heart pumps. The anesthesiologist monitors things like blood pressure, heart rate, and sometimes central venous pressure very closely to manage these physiological changes caused by the prone position.
And eye protection is specifically called out. Why is that so critical?
When you're face down, especially if the head isn't perfectly level or there is external pressure, the pressure inside the eye, called the intraocular pressure, can rise significantly. Prolonged high pressure inside the eye can damage the optic nerve, of course. So avoiding any direct pressure on the eyeballs is paramount.
Lastly, ergonomics. Thinking about the surgeon and the setup.
Right. The surgeon is typically positioned at the head of the table, the operating table height, the microscope position, the instrument tables. Everything needs to be adjusted for optimal access and comfort for the surgical team during what can be a very long operation.
Okay, let's dive a bit deeper into that head positioning, the flexion and turning. You said it's not one size fits all.
Not at all. It's highly tailored. The exact degree of flexion or rotation depends entirely on the specific surgical target and the patient's individual anatomy.
So head flexion, bending the neck forward, we know it can help access, but what are the hard limits? What are you watching out for?
The main concerns with the excessive flexion are one, the impairing venous drainage from the brain, which can increases the intracranial pressure. Sorry. Two, potentially causing spinal cord ischemia by stretching or compromising its blood supply. And three, as we said, kinking the airway tube.
So, the goal is just enough flexion for surgical need without hitting those danger zones.
Precisely. It's about optimizing the view while maintaining safety margin for blood flow and airway.
And what about head turning, rotating the head side to side? When is that necessary?
Head turning is often needed for approaches to the side of the posterior fossa, the area containing the cerebellum and the brainstem, or lateral aspects of the upper cervical spine.
And the risks there?
Similar concerns, but focused on different vessels. Turning the head too much can potentially kink or compress the vertebral arteries, which run up through the neck bones to supply the back of the brain, or the jugular veins restricting outflow again, risking ischemia or congestion of the brain.
So it sounds like every adjustment is a calculated risk-benefit analysis.
Absolutely. We consider the patient's neck mobility, any pre-existing vascular issue, the surgical goal, and constantly monitoring the neurological signals if possible during positioning and the procedure itself. It requires meticulous planning and execution.
Okay. So wrapping up our deep dive today, it seems clear the prone position is, well, a really essential tool in the neurosurgical toolkit.
Definitely vital for certain procedures.
But it's complex. It offers that crucial access, but demands incredible attention to detailed positioning, padding, monitoring to keep the patient safe. And that specific positioning of the head, the flexion and turning, is a critical piece of that puzzle, carefully customized every time.
Couldn't have said it better. It's a constant balancing act between surgical need and the patient safety.
A fascinating look into a complex world.
It really is. And thinking about that delicate balance, it really makes you wonder what's next? What kind of future innovations in, say, real-time monitoring or even new position devices might emerge to refine this process further, minimize those risks even more, and optimize outcomes for patients. Thank you for your questions. See you. Bye.